Assalamu alaikum. A very good morning, good afternoon, good evening to all of you joining us for different parts of the world. I am Dr. Sohaila Chima. I'm an associate professor of clinical population health sciences and the assistant dean for the Institute for Population Health here at Weill Cornell Medicine in Qatar. So we welcome you all to today's session of the Population Health and Wellbeing series. Just as a reminder, the objectives are we are discussing contemporary critical topics relevant to healthcare, medicine, population health. We examine evidence-based practices which are germane to public health and patient care, and we describe opportunities and challenges in the evolving face of healthcare and population health. So just some housekeeping before we begin. Your cameras and microphones have been turned off. Please use the Q&A feature to type your questions and comments. You can also use the chat feature. We will be able to see your questions. So if you're unable to put it in the Q&A feature, please go ahead and put it in the comment section, and we will be able to view your questions or comments. Questions will be addressed at the end of the session, and I will be moderating the session today. So as you know, this is an accredited activity, and it's accredited both by ACCME and by DHP accreditation section here at the Ministry of Public Health. So just a little bit about evaluations and certificates. So the post-activity evaluation, it will be available in your Cloud CME account by October the 17th. So you will be able to access it. And again, healthcare practitioners which are licensed in Qatar, they will only receive their credits once the QID and MOPH license number is provided. This, of course, as many of you know who are practicing here in the state of Qatar, was following basically a circular which came from the Department of Healthcare Professions, Ministry of Public Health. So you'll receive an email notification once the evaluation is available in your Cloud CME. And once you complete that evaluation, you'll be able to download the certificate automatically from the Cloud CME portal. So we have a wonderful speaker today, and it gives me really great honor to introduce the speaker. It's Professor Igor Rudan. He graduated from the University of Zagreb Medical School, Croatia in 1995. He obtained 2 master's degrees in anthropology and in epidemiology. He also has 2 PhD degrees in public health and genetic epidemiology. He's published more than 600 research papers, 12 books, 12 book chapters, which have received more than 225,000 citations to date, with an H index of 170 on Google Scholar. He's received more than 35 national and international research awards and professional recognitions. He's led 31 research grants totaling about Great Britain, British pounds 41 million. In 2001, he founded the Croatian Biobank, 1001 Dalmatians in isolated populations of Croatian islands in Dalmatia region, which contributed to the discovery of biomedical role for more than 2,000 human genes. In his international health efforts to reduce global child mortality, he served as a consultant for the World Health Organization, the UNICEF, the Bill and Melinda Gates Foundation, the World Bank, Save the Children, and others. He founded and has led the Journal of Global Health since 2011, WHO's Collaborating Center in Edinburgh in 2013, Center for Global Health at the University of Edinburgh 2015, and the International Society of Global Health in 2019. Professor Igor Rudan, a very, very warm welcome to you, and over to you.
Hello, hi. Hello, everyone. It's wonderful to accept this invitation, and I'm delighted to be here. Okay, so you see, I've been doing many things, obviously, right? And one thing that I've been doing more than other things is clearly global health, because I set up the Center for Global Health in Edinburgh, and the World Health Organization collaborating center. Then I started the Journal of Global Health and set up the International Society of Global Health. So obviously, I'm quite interested in global health. But funnily enough, you do many, many, many things, and you just never know which one will eventually be better or more interesting or successful than the others. You just can't predict it. I've spent lots of effort, you see, working in Croatian islands, mapping disease genes, and then later reducing child mortality. But I don't know if many people know me for mapping disease genes or reducing child mortality. What people mainly know me for is something I've done as a consultant once about 17 years ago, and that is the CHNRI method, which has been widely used now as a way to prioritize health research. And I remember distinctly when I was offered this consultancy, I needed to buy a garage and I didn't know how to do it. And suddenly this consultancy came and I was already overcommitted doing many things. But then I said, okay, we need the garage. I'll just say yes. So this is how the CHNRI methodology really, started. And I'll tell you what it is because, funnily enough, that's probably the biggest contribution that I've done. And although I tried very hard to work in other fields, that's how life works. Let me see if this works. Okay, so first I need to disclose that I have no relevant financial interest, no more garages to buy. I am just here basically as a friend, and I will not be discussing any unapproved drugs or products. Okay. Now, objectives of this today's talk are to outline an introduction to the field of research priority setting and describing the instruments of health research and discussing how to acquire a skill to conduct the CHNRI process to set research priorities in an area of science. Now, before I start, can I just ask Sohaila to confirm that you can all hear what I'm saying and see my slides, because it would be a pity to speak for an hour and not having anyone listen to me. Hello?
All good. All good.
All good so far? Okay, great.
Yes, excellent.
Okay, then let's go back to that time when I needed a garage and when I was approached by this unusual collaboration of scientists called Child Health and Nutrition Research Initiative. They said, look, the World Health Organization wants a process for setting research priorities, because whenever they sit down every 5 years to decide what are the research priorities, they all basically start fighting among themselves, and they just abandon the process because everyone thinks that their idea is the best idea, right? And nobody wants to admit that somebody else is better or more important. So they wanted a process, and the World Bank was happy to fund the work on some transparent process, and the WHO didn't want to do it within themselves. They set up the research wing called Global Forum for Health Research just down the street in Geneva, because they were just worried that this can't be solved and that this will always end up with people fighting and never getting anywhere. So basically, in 2005, it started in Geneva. Global Forum advertised for a consultant to solve this problem, and the World Bank was giving $500,000 for this and as a project, right? And I said, okay, I'll be put forward by this collaboration, Child Health Nutrition Research Initiative. And they picked me over a number of other consultants who tried to get this project. And then this started. What I did with this money, I gathered people from all sorts of various fields and expertises, because it was clear to me that this is a complicated thing to do. And I after a while, I wasn't even sure whether I should have gotten into this, honestly. So, we met in Baltimore after Geneva, and then in Dubrovnik in Croatia, and then in Mumbai in India, and started talking about this. And there were about 20 of people in this group. And in 2006, we kept meeting in, I think, Toronto and Cape Town, and you see Baltimore again, and Cairo in Egypt. And then in 2007, we kept meeting further in all these lovely cities. And in 2007, we came to Beijing and realized we ran out of the money and we had no more money to meet. And we had to actually finally published something that we call the CHNRI methodology for setting health research priorities. So it was in Beijing in 2007 where we finally then said, okay, we will just, we are still not sure exactly how to do this, but we will at least, after these 12 meetings, we really need to be able to say something about how this should be done. So 10 years later, this is a paper by the World Health Organization, which is looking into various methods that are used for setting research priorities. And you can see that 10 years later, CHNRI method was #1 used method for setting research priorities. And that's even more interesting given that it was introduced in 2007. And these are all the 21st century papers into this pie chart. So clearly, people started using CHNRI method. Now, let me try to explain why I think this may be the case. So whoever wants to do some sort of a prioritization process for saying which health research is more needed than the other, and where should we put the money for health research, the first question is usually, I mean, how are you going to be fair to every single possible idea? Because, you know, the spectrum of research ideas is infinite. And how are you going to make sure that you didn't forget any important idea? So this was a very difficult question. How do you manage infinity? Mathematicians can't do it. And so I started thinking together with the group that supported me, and we thought, okay, let's think of all the people in this population here. And if every single one of them declares what are their health problems at the moment, and we put it all in one big barrel, that would be the burden of disease of those people that we are trying to remove using health research, right? And then the trouble is that this is never as simple because some of these people will be also exposed to a risk factor such as smoking, some of them to another risk factor such as drinking, of them might have indoor air pollution, and you see some of them might even have all three or two of them combined. And because of those additional risk factors that people are exposed to, the burden of disease is actually even bigger. I'll show you now. So because of those three risk factors, it goes even up. So this is the situation when you come to some population. They have a burden of disease which is partly inherent and partly caused by additional risk factors. But then, you know, the situation is never as bad as it seems because the government or people themselves are doing something. So they are covering themselves with some interventions. For example, intervention 1 might be, I don't know, vaccination against some problem. Intervention 2 might be a support group. And, you know, because of that, the burden is actually slightly smaller than it could be, right? So one thing that you can do through health research is understand this sort of architecture of the disease burden in some population. So clearly that is one important role for health research to tell us what is the burden of disease, how big is the burden of disease, and not just how big is the burden of disease, but also what is it composed of? What is the architecture? You know, what kind of combination of inherent burden plus risk factor effects plus intervention effects, you know, risk factor negative effects, intervention positive protective effects. What kind of combination is leading to this burden of disease? So that's what we really want to know for some population. And this kind of research is called the descriptive research. So now moving on to something else that is also interesting. Let's say that we now have this situation and we would like to make it better. But using the interventions that we have, which is intervention 1 and intervention 2, and also using the money that we have for this intervention. So what could we potentially do? We can realize that this intervention 1 can be made better by, you know, reaching more people. And it could reach more people if, for example, there is some celebrity supporting this intervention that is very popular, like a football player or I don't know. So then suddenly, you know, you make this intervention better if you ask a football player to endorse it. Or intervention 2, we may do research and realize that intervention 2 is given to wrong people. These people are not actually drinking. So why don't we give it to these people here who are exposed to drinking or maybe smoking? So suddenly you are making, with the same interventions that you already had and with the same amount of money that you already had, you're actually, thanks to research that you conducted, which is called delivery research or health policy and systems research, you reduce the burden of disease, okay? All right, so you see that health research can reduce the burden of disease. Now, let's take that situation further, and then you may do some research on the interventions themselves. You can say, look, this intervention one, the vaccine is only covering maybe 5 serotypes. Why doesn't it cover 15 serotypes? Let's make a better vaccine. So then you make more intense vaccine, which is more effective. Or intervention two, you realize that it was not thought through well, it was not acceptable to people, but if you tweak it, you make it more acceptable and more people actually come. So basically changing interventions that we already have to make them better is also a kind of health research, which we can call development health research. And thanks to that, you know, we have more effectiveness, and thanks to that, we have less burden of disease then. So that health research can also affect burden of disease. And then we have the fourth stream of health research, which we can call discovery. What does this do? It creates completely new interventions that we don't have yet, all right? So intervention 3 or intervention 4. Suddenly, you know, we have some new interventions thanks to completely basic new research. And thanks to them, we reduce the burden of disease further. So you see how health works. Basically, we realized that there, you know, although universe is infinite, just like the number of potential research ideas is infinite, but we can maybe split it into 4 separate small universes, which are also still infinite, each one of them, but at least we got somewhere. We are not dealing with a huge, endless universe. We are now at least knowing, well, there are 4 universes that comprise that one big universe. And within those 4 universes, we can say what falls into which one. Okay, so we're no longer just completely hopeless. So we call these 4 avenues of health research the 4 Ds: description research, delivery research, development research, and discovery research. And what is just the generalized version of this research description? So you can basically, if you have a problem and you want to remove it through research, you can ask yourself 4 questions. How do we describe this problem well to understand it? Then how do we increase the efficiency of what we already have to tackle that problem? Then how do we improve those means that we have to make them even better? And then finally, how do we develop a completely new and better means to deal with that problem? So those are just the 4 things that you can generally do whenever you're faced with any problem in life. You know, firstly, describe it really well. Then see what you can do to mitigate it and, you know, increase the efficiency of how are you mitigating it. Then improve whatever you have against it. And then finally, find even more things against it. Those are the 4 things that you can basically do against any problem, right? Okay, then moving on, we now realized once we split this one big universe of ideas into 4 smaller but still endless universes of ideas, that within each of those research instruments, as we call them, there are research avenues. They are still very broad. For example, if you want to describe the problem, you can measure the burden of the problem, you can try to understand risk factors, or you can evaluate the existing interventions. If you want to do health policy and systems research, you can look at the way to reduce exposure to risks or to deliver better interventions. Then in the development, you can make a research to improve deliverability, affordability, and sustainability. And in discovery research, it can be basic clinical or public health research with a completely novel interventions to produce, okay? So now within these research avenues, we realized that there are even more specific things to do. You can then define research options. So what would be research options? That would be like the titles of a 4 to 5 year program. So still quite broad, but not as broad as the avenues. And then what would be the research questions? Well, that would be like the title of the research paper level. So very, very specific. So we realized that you can make a prioritization at the level of research instruments, level of research avenues, options, and questions depending on the depth. So when some people are suggesting ideas, then we can immediately, now having this framework, we can immediately say, okay, this idea is at the level of research avenue and or research option, and it falls under description, under the evaluating existing interventions. Suddenly, we got a framework that allowed us to kind of feel or cover all the fields and at least understand where each idea belongs, all right? And thanks to that, we could be reasonably sure that we are covering most of things that can be done, right? So that was a huge progress from a completely endless set of ideas. So, and we made a recommendation that this research option is ideal for prioritization because it's kind of intuitive to scientists. They have to write research grants. So this is a level of title of the research project, right? Okay, so number of feasible research options is now very large, but it's at least now becomes manageable. We would end up with about 200, 300 ideas for research projects, and suddenly there would be overlap after that and saturation. So we realized that this is not really endless in the real world scenario. So that was one big problem that we solved. Now, the second big problem that nobody managed to solve before us was how are you going to prioritize something that is completely unpredictable? You can't predict the future, so outcomes of research ideas, you can't predict where the research will take you, right? So how can you say that one idea is better than the other when you can't know the future, right? So first problem was infinity, and second problem was that the future is unpredictable. So, you know, we had to cope with the infinity. We kind of managed to split it into many smaller infinities. And then we were happy that we were covering the whole spectrum. And now the problem was we can't predict the future. What are we going to do? How are we going to handle that? So we decided that actually you cannot predict the future, but what you can do is be reasonably certain that if you define the context very, very well, then you will be able to predict the future to a large extent if you use certain criteria. So the key was defining the context. And the context for health research investments can be, you know, what is your motivation? Why are you investing in health research? You know, the governments might invest and they just want to reduce the burden of health problems in the population. But if you have a pharmaceutical industry investing in health research, they're industry. They don't care about maybe necessarily reducing the burden of health. They care about patents and profits because they're industry and they need to make a big profit. And then if you're like a philanthropic donor like Bill Gates or the Qatar Foundation or whatever, you may not care about patents at all or even reducing the burden of disease in the whole population. You might just be after some big win, like solving the problem of malaria or eradicating malaria or, you know, or eradicating polio in the world or something. So basically, you know, you can have your own priorities if it's your money. So basically, we have completely different donors, the governments, the pharmaceutical industry, and the philanthropic foundations. And clearly, they have completely different motivations of why are they investing. And nobody is investing in health research without expecting some return on that investment. And we can see that the return on investment for the governments is reduction of the burden of disease. Return for pharma is profits and patents. Return for foundations are maybe some prizes and big wins, right? Okay, so what investment style will someone want to use when investing in research? Well, you can use a responsible, balanced style if you're a government. You can be risk averse if you are a pharmaceutical industry because you don't want to lose the profits. Or you can be risk seeking. You can be Bill Gates and say, look, I'll invest $2 billion. I don't care if that's going to solve the malaria problem, right? So you can have completely different investment styles. And then population you may be targeting might be the whole population or the region of the world or even subnational or national or just age group or just certain disease. So you need to define what is your population you're targeting. And then what is your focus? Is it the whole burden? Is it just one disease or is it just one product, one intervention, vaccine, something like that? And finally, very importantly, in what time frame do you expect these returns on investments? Do you expect this within a very short time frame or middle time frame or a very long time frame? Because your investment priorities are going to be completely different depending on the time frame that you are expecting returns from your investments in health research. So once we realized that, we had to define what is the health research. We said, okay, health research is a process that starts with a research question. And then if you answer that question well with your research, then you're going to generate new knowledge. But then you need to translate and implement that knowledge to reduce the burden of disease. Only then that becomes a full health research process, but what happens way too often is that once you ask your research question and do your research and new knowledge is generated, after that, the novelty and attractiveness of these findings and you publish in high impact journals and you get media coverage and lobbying just takes you to another research question, and you're just constantly trapped into this cycle of generating more and more and more research and more papers and knowledge without ever actually taking time to translate and implement and reduce burden of disease. That's considered by researchers boring unless industry takes it up. And then, and even many grants, sadly, many grants that, are based on ideas on how to translate the knowledge and implement it to reduce the burden of disease, they get rejected because this is not seen as like a proper novel research. So the science has a danger of being trapped into this cycle where it just constantly produces more and more papers and knowledge without ever doing anything to translate it and implement it and reduce the burden of disease. So, we need a shift in funding, in thinking among the funders, and they have to start funding far more of this translational research like NIHR does in the United Kingdom. So if we really want to do everything properly, then we suggested that once you define your context very well, then some criteria can actually help you to tell which idea is more realistic than the other. And what are those criteria? Well, to get from research question to new knowledge, needs to be answerable in an ethical way. To get from knowledge to translation, it has to be efficacious or effective. To get from translation to disease burden reduction, it has to be deliverable and affordable. And then even when you do reduce the burden of disease, one idea can be better than the other if it has bigger potential to reduce burden of disease. And also if it has a bigger potential to be equitable than the other idea, and that the burden of disease is actually equally distributed among all parts of population. All right. So clearly, those are the 5 possible criteria, but different contexts will have a completely different criteria. You could also look into public opinion, local research capacity, community involvement, generating patents, sustainability, and so on and so on. And decisions on research investment priorities based on different criteria will necessarily conflict each other. So we need more of those criteria. Okay, so now we managed to sort out the problem of infinite number of research ideas, and we managed to sort out the problem of unpredictability of the future, because if you define very, very well what is your context in which you're investing and what are your expected returns, and if you define this process in a way that there are some criteria that measure the likelihood that you come from the step 1 to step 2 and step 2 to step 3, step 3 to step 4, then we can predict what's going to happen very, very well, right? So we solved those 2 problems, but there was the third problem, and that is, how do we measure and rank all feasible ideas in a fair, transparent, and replicable way? And we didn't know this really, how to do this, because in Delphi exercises, everyone was just shouting, and whoever was shouting louder than others, they usually got their priorities. And we didn't want that to happen. So we started looking into something that was happening in 2007 in parallel with our work, and that was crowdsourcing. So the word crowdsourcing only dates back to 2007, and there were some very important books published then, such as The Wisdom of Crowds and Why the Many Are Smarter Than the Few. And the central idea was that a diverse collection of independently decided individuals is likely to make certain types of decisions and predictions much better than any experts in a vast majority of cases. And that was good enough for us. We thought, okay, that's the way we'll do it. But there are some requirements for the crowds to be wise. There has to be diversity of opinion, and each person who contributes their knowledge and opinion should have private information, even if it's just a completely eccentric interpretation of the known facts. Also, everyone needs to give their opinion completely independently of other people's. So not like in a Delphi process where you see the important guy saying something and then you don't want to oppose him because he may remember you. So basically, you just are free to say whatever you want. Decentralization. People need to be able to specialize and draw on local knowledge too. And aggregation. There has to be mechanism for turning private judgments and opinions into collective decision. And this is what the CHNRI process is. So basically, we developed the process that is based on crowdsourcing. We developed the process where we are trying to measure collective optimism of the best experts in the world towards various criteria and various research ideas. So in a typical consensus development process such as Delphi, typically people would do background reading, then they would meet in a room, have round one of discussions, interact, try to convince each other that their ideas are better. Feedback is fed to experts, and then there is a round two of discussions, and then there is some consensus on priorities. See, all of it is problematic at every step. In the CHNRI process, there is no background reading, no discussions, no interactions, nothing. So everyone just says what they think in their own space. We can still give feedback to them, and we can even do agreement statistics to find which ideas cause the biggest disagreement between people and which not. And there's no need for consensus. We just measure collective optimism, whatever it is for each idea and each criterion. So let me show you how this actually works in practice, okay? So this slide actually captures the whole CHNRI process. Okay, so firstly, you invite the funders who are paying for health research. They want your advice. And you ask them to define the context. You ask them to define the criteria. And you ask them to select the management team to conduct the CHNRI. Once they've done that, you ask them to politely, to leave, and you bring in the management team. So the management team is usually tasked to choose a large group of technical experts, the people who know most about that problem in the world. That might be like the 200 most productive researchers in the past 5 years or something, because they are going to be competing for those grants anyway. And then you invite those 200 most productive researchers, you ask them to submit the best ideas, say to how to tackle dementia or how to tackle anything in health. And then you receive a long list of many, many, many ideas. And then the management team needs to consolidate that list, remove the duplicate questions, and eventually bring it back to the experts to score those ideas according to the criteria. And when they do that, you can still do something else. You can get stakeholders involved. So those are the people who don't have so much knowledge about research and that field. They're not dementia experts or obesity experts, but they still can have their own opinion and values. So they can say, okay, look, we don't know anything about the science of dementia or the science of obesity, but we see that you're using criterion of equity and criterion of effectiveness. So for us, we think that equity should be weighted just as much as all the other criteria combined, because that's important to us. Or you can come to the Gates Foundation and they say, we want the maximum burden of disease reduction. We don't care what it costs, whether it's equitable, whether it's, or you can come to, government who say, look, we don't want to fund something that is not effective. So we want effectiveness to be the key criterion, and so on and so on. So once you have done all this scoring process, you end up with a list which looks like this. I mean, this list would have hundreds of questions, and this is what the top 4 could look like, right? So this is the exercise on diarrhea in children, and the top ranks were what are the barriers against appropriate use of oral rehydration treatment, and then assess integration of zinc treatment for diarrhea, then optimal dose and duration of zinc, and so on and so on. And you just look, is this question answerable? You see research type. It's health policy and systems research, or basic research, or epidemiological, or development research. Now, what did we do? We measured the collective opinion of people who are top experts, and 87% of them said, yes, this would be answerable. 89%, yes, this would be effective. 100%, yes, this would be deliverable. 77%, yes, this would reduce the burden, and so on. And suddenly, you see that out of the blue, out of thin air, out of nothing, you just assembled 200 people, and based on their collective opinion and knowledge, you created a table with ideas, and you not just from their heads you extracted the best ideas, but also from their heads you got their collective, you measured their collective optimism towards how each of these ideas satisfies each of the 5 criteria. And then you add the criteria and you get your priority score. You can even tweak it by putting more weight on certain criteria over the others, okay? So that's what you get. You create a very useful list without having to do the Delphi, because in Delphi you can only talk about 1 or 2 ideas and 1 or 2 aspects of those ideas and so on. Here you talk about hundreds of ideas and give each one of them number in terms of collective optimism towards satisfying some criteria that is important for the future, okay? So this is how we resolved it, and basically we are measuring collective optimism, we are using large number of health research ideas, and advantages and disadvantages of each of the idea become transparent. The scores are intuitive to everyone from 0 to 100, and the result is completely democratic. And you know what's beautiful? If you had like 100 people contributing to this, everyone can only contribute to 1% of the final score. So nobody can influence this process more than 1% if you have 100 people engaged, yet you still get the results that are everyone's, but no one's at the same time, okay? No one can later say, I put this idea in and I made sure that it's heard about and it's noticed. No, it's all just completely democratic. Okay, so then when the CHNRI was first presented, there were some people who got really worried that CHNRI is now going to start telling donors what to do, but it's not. It doesn't tell donors what to do. It just offers information that protects you from risky investments. You see, it's easy to conduct. It costs practically nothing to conduct. It's easy to score because, many thousands of researchers have already participated in more than 150, almost 200 exercises now. And it's easy to publish this because we published now 200, actually, I should update this slide, in leading journals. Ease of interpretation, list of ranked questions with scores is very easy to interpret. So this is basically the same as coming to stock market and wanting to invest and expecting some return. And then you would have many, many companies listed, and you would want to know their values of, price over earnings or price over sales and so on. So this is just the same. It's telling you what are your options and what are their strengths and weaknesses. And then you can develop your portfolio any way you want, if you're taking more risk or less risk. And very, very similar thing already exists with lists of world universities. You see, you have a long list of universities, just like research questions, and then you have like scores between 0 and 100 on one criterion, other, third, fourth, fifth, sixth. So this already exists, and this is not telling you where to send your child to school. It's just telling you what kind of risk are you going to have to face, and with what, if you're sending it to Chicago over Edinburgh, basically, and what is better, what is worse in Chicago versus Edinburgh. So that's all it does. It protects you from making big mistakes, right? Okay. Now, so if we want to summarize, what is then the CHNRI method for setting research priorities? It's a process that prioritizes a large number of competing ideas using a defined context, transparent criteria, and collective wisdom. So it starts with investors who define the context, criteria, and define expectations. Then it goes to technical experts who list and apply criteria and score the research options. Then to stakeholders who can develop weights and thresholds for criteria. And finally, adjust final scores, and this gets fed back as a report to investors. See, this is what you get. Research priority score is basically the sum of the levels or collective optimism on 5 different criteria. And in this case, it's green. You see, it's 60% for the answerability, 80% for effectiveness and deliverability, 60% for equitable. And then you can either have thresholds. You can say the stakeholders could say, look, we want to place some thresholds. And if the idea in one criterion doesn't pass the threshold, then no matter how good it does, well, it does in the other 4 criteria, it should not be considered a research priority. And also this A, B, C, D, E could be different weights that they say based on their value judgments, okay? All right. So we described in 2007 after Beijing and 2008, we published 4 papers, which then described principles and practice and the universal challenges and conceptual framework and how to address the values of stakeholders, and eventually gave guidelines for implementation of the CHNRI method. So what happened after that? After that, people started using it a lot and publishing the results a lot. And we had, you know, just in 2007, very, you know, less than 10 years later, we had already more than 50 exercises published. And I reviewed them at the time in 2016. So what was I interested in when I reviewed them? I was interested in how much are people making of the flexibility of the method? How much are they changing it? And for what are they using it? So I realized that 30% of them used it at the global level, 55% at low and middle income country level, 11% or 12 at national level, you know, and there were some other like crisis setting. Time frame we set as a template to be 10 years, and 72% really did use 10 years. But some people wanted to have a shorter time frame in the context, and some people wanted to have even 15 years or more. And then in terms of population under study, mainly it was done in children and neonates and adolescents. Clearly, this is a reflection of Child Health and Nutrition Research Initiative being behind it. But basically, little by little, it started going out and spilling to all groups. And then we were looking at how many of them actually used the stakeholder input. And most of them didn't feel that they needed much stakeholder input. They were mainly interested in the input from the researchers. Then, interestingly, you know, we defined those 5 original CHNRI criteria. How do you get from question to answered question to new knowledge to burden reduction? So we were interested in how many of those criteria that were offered as a template were actually used by people in real life. And we realized that as many as 2/3 of exercises have actually modified our set of criteria. And we were delighted with this because we wanted this method to be flexible. And not just that they've changed the criteria, they changed even the number of criteria they used. Some thought 3 were enough and 4. Many stuck with 5, but only less than 60%. Some expanded to 6, some to 9, and some to 13 criteria, okay? And then we wondered, okay, which criteria were most likely to survive and not be dropped? So in 81% of exercises, answerability and equity were retained. Impact on burden in 76, deliverability 69, effectiveness 65. And then we were wondering, okay, but what are those additional criteria that people who use the method have introduced? And we realized that feasibility and acceptability were important, and also low cost, sustainability, relevance. And then the others were a bit less, but also fills key gap, applicability, fundability, and so on and so on. So at that point, with about 50 exercises published, we had more than 5,000 experts approached, so about 100 per exercise. And then, 60% of them submitted ideas, and then we had about 3 ideas submitted per expert. And then a redundancy rate for ideas was high, 54%, and I'll come back to that later. And then number of papers at that point was 43, and so on. And then many people asked us, so how can we be sure that this method is really stable, that the same question would always get the same score? So we tried to answer this by plotting, without telling to anyone of the scorers, we plotted the same question worded slightly differently, 3 times in the long list of questions so that they don't realize. And, we demonstrated in an exercise like this that that same question in 3 versions was then ranked 6, 7, and 15 with a very, very similar score. So clearly, the scores are stable given by experts. But then, even more importantly, we were asked, okay, but what if we ask some other group of experts, not just those 100 or 200? What if we ask another 200? Would we still get the same results? And this is what we've done. We've done a simulation of rank correlation, so which means that these ranks of questions get saturated after enough people, and the number seems to be 45. After 45 people are well-minded people with some knowledge of the question of the area are given their scores, then you get the table ranks that they're so stable that you can add another 1,000 people and you're not going to change those scores almost at all, So you see, there is a saturation. So that we demonstrated quantitatively that the human collective opinion very, very quickly saturates. And it's funny because social scientists have been saying for decades that you just need to do 20 or 30 interviews and you get saturation of all information that you're hearing. And epidemiologists didn't believe them. They were saying, oh, we need millions of sample size of 1 million or 2 million to know anything. Whereas this shows that really, indeed, a human quantitative opinion expressed as zeros or ones, yes or no's, is very quickly saturated, and you cannot change the ranks of priorities after that. So people ask me, why has CHNRI expanded so quickly, and why does it work? I would say, firstly, because it's systematic. It gives you acceptable handling of an endless spectrum of research ideas. And then we realized even that this spectrum isn't really endless. When we ask about 140, 160, 180 experts, as you see on the x-axis here, we start seeing a very, very big rate of repeating the same ideas, which leads almost to saturation after about 300 experts, which means that this spectrum isn't really endless. Obviously, the spectrum of ideas that are feasible in any given context is not completely endless, but it does start to saturate. And that's what I said I will comment on with those 54% of double questions. Then the second reason, I think it's completely transparent. So, you know the context, the criteria, you have the input from every expert, everything is transparent and replicable. Then it's democratic, everyone gets to vote, and everyone votes is the same way. It's inclusive because it gives role to donors, researchers, and other stakeholders. Then it's flexible because you could easily modify it. And in this particular exercise, they replaced effective with gaps for scale up, deliverability with national policy attention, equitable reduction with ownership by local actors. You can easily change it and tailor it to your needs. And finally, it's very simple. It's really simple to do. All you're asking people is to say yes or no. Do they believe this would be answerable, effective, and so on. The scores you get are intuitive, easy to understand, it's cheap to conduct, and eventually easy to publish. So it became quite popular. And clearly, in global health, we can modify it to start prioritizing investments in healthcare and not just health research. We can also start using it for emerging health technologies, for prioritizing funding for development assistance for health, and also for global health governance. But even beyond global health, this is a simple and cheap tool that allows assembling and analyzing collective knowledge and opinion of many people on many ideas. So you can use it for anything. You can use it in donor agencies, international organizations, for-profit companies even, in setting their own strategic priorities among many different ideas based on collective knowledge of the most qualified employees. So if you want to read more about it, there's been a series of 7 articles published in Journal of Global Health in 2016 and 17. It was called Setting Health Research Priorities Using the CHNRI Method 1 to 7. And if you want to see some good examples of implementation, there has been a review of the first 50 exercises. And one of the biggest ones was done in India with almost 1,000 experts, 256 medical schools, more than 4,000 ideas. So you can make it really big if you want to. More than 15 exercises were published in the Lancet or PLOS Medicine up to now. Now, to place a solution of this problem of setting research priorities in a broader system for producing knowledge, you can think of all this here as how are we producing knowledge today in the first place. And you can see that there are needs to coordinate funding among the donors, need to prioritize among many research ideas. That's what we solved. But, there is a need to coordinate funding among donors too. Then there is a need to recognize successful research, then need to ensure broad and rapid accessibility, and finally need to evaluate returns. So clearly, more tools and methods would be needed to address those other needs as well to make a global health research system more effective. And finally, what we're working on now is a software that would allow online conduct of this CHNRI process. We will probably rebrand it into Ideometrics because we're trying to measure ideas, and then you can use it for anything, not just for health research, which CHNRI was for, but also for just any ideas within private sector, governments, or just solve any problems. At the moment, one country is using it to address ideas how to improve the state of women in that country and empower them. So it's a very societal issue. In the UK, they are now approaching us about how to increase economic growth of the country. And, how could we get maybe the top 200 financial minds and people from business and bankers to tell us this and see what they all think collectively. And, there's many other examples. We are hoping, to work with one big multinational company to ask top 200 managers all over the world to what would be the best business ideas for the company in the next 5 years or so, So you can really use it for anything, and we're going to try to develop a software to enable, its wide use. So thank you for your attention. That's all from me for today, and I'd be very happy to answer any of your questions.
Great. Thank you so much, Igor, for that wonderful presentation. So really, really comprehensive. So we have some questions coming in, and I will start with the first one. So the question is, what role do experts play in the CHNRI prioritization process, and how are they chosen?
Okay, so you see, we conducted various experiments, We conducted experiments with medical students of year 2, and we asked them to judge on the questions that were related to year 1 knowledge, and they all nailed it as a collective. They guessed correctly the number of bones in the body. They guessed correctly everything. But then we asked them some general knowledge questions, like when did Shakespeare write Hamlet, which year, and so on. And as a collective, 200 students didn't guess that well. And then we asked them questions from year 1 astronomy. What is the distance from the sun to the moon in kilometers on? And they guessed collectively completely wrong. So that demonstrated that you're going to get far better answers if you're asking people who are knowledgeable about something than if they are just general crowd or they have absolutely zero knowledge, right? So,
Right.
zero knowledge would be medical students checking astronomy. And we published this to demonstrate that you need experts. So now clearly experts are going to give you much better results, because if you have no experts, if 200 of us here were asked what is happening at some planet in a distant galaxy where we don't understand anything, we would all say yes, no, yes, no. And every answer would eventually be 50% because there would be similar number of people saying yes or no. When you start deviating from 50%, that means that there is some knowledge involved. And this is why you need experts, okay? And experts manage to discriminate well between these many ideas so that some are very high up and some are very little down. The minute you start using someone else than experts, you get regression to the mean, a lot of noise and meaningless input, and then all ideas start looking similarly good or bad. Now, how do you choose the experts? So in health research, it's quite easy. We were thinking, look, who are we doing this for? We're doing this for the funders so that they give out grants. And who is going to be competing for these grants? Well, the people who have been the most productive in this area of research in the last 5 years. So basically, one way of choosing the experts is to go on Web of Science and rank all the researchers in the last 5 years by the number of papers, and then invite top 200 or maybe the top 100 most cited people in this area or whichever, but just make it defensible, because if someone else comes and says, look, why I wasn't invited to these 200? Well, because your output was not in the 200 most cited, and these guys had more citations, so we wanted to hear from them, not from you. So that's how we choose the experts usually. Yeah, and it has to be kind of yeah. But surely we need experts, and that's how we were choosing them.
Right. Great. And just to reiterate, like what you're saying, basically this method works best with experts being there. So, like you have in other research settings, you may have community participating, and things like that. But that is not necessarily possible here because you gave that example of the medical students and, like the noise that you can collect.
Exactly. We don't want to exclude the community. Okay. So this is why we have
Right.
this larger group of stakeholders. We still give
Right.
a voice to community. Community can still do a lot to change the results. But you
Mhm.
see, what we are just saying is, look, let's not give community the chance to judge on some very sophisticated research because they just don't know anything about it. So why don't we just give researchers a chance to give ideas and researchers
Right.
chance to rank ideas? But then
Right.
what community can do is they can say, okay, look, you use these 5 criteria. We think that equity is way more
Mhm.
important than answerability for us. So we as
Sure.
a society, if you want this to be applicable to society, give more weight to the score of the equity over the score of answerability, and then recalculate the results. So you see, they can still influence, but they could influence through the appropriate way and not inappropriate way.
Right. Okay. Um, so Iger, how, of course, the scoring is there in the system, right? So, I mean, we talk about scoring subjectivity. So how is that mitigated in the process, in this CHNRI process?
You see, we are using the wisdom of crowds because
Mhm.
every opinion is always subjective. And what we wanted is, World Bank and World Health Organization and everyone with the
Mhm.
movement of evidence-based this and that and evidence-based
Yes.
medicine, they realized that, at one side you have these guidelines and really becoming more rigorous about everything. And at the other side, this research prioritization is you get 20 people in the room and whoever is the loudest or two voices become 20 voices, and then they leave the room, become 120 voices, become 1,000
Right.
voices, and everyone is saying this is a priority. And this is we could demonstrate actually how incredibly wrong this was, because we were looking, once we started seeing what is the burden of, say, childhood pneumonia or meningitis and how much money it receives, the research for this, and on the other hand, dengue fever or something else, which is tiny but has 6 times more research, then we realized it's gone completely wrong. Like even in the stock market, you would never see this sort of discrepancy as you saw in how terribly wrong was you know, how terribly mismatched was funding for research on various diseases. And, you know, I would imagine that HIV/AIDS gets far more than malaria and or particularly tuberculosis, you know, so it's all about who shouts louder than others, and we should not do it that way. We should really align it with the burden on the society.
Sure. Thank you for that. Another question's about the sample size. How much is the attrition rate that is acceptable for research? Is it 10% of the total sample size? How do you decide on the sample
Okay,
size?
so far, when we, as I showed in one slide, when we approached like 200 top experts in any field, about 60% of them were happy to share ideas.
Okay.
And that's quite stable. And then once we went back to those 60%, then more than half of them, more than half of those 60%, so more than 30%, eventually scored. So scoring is much more time consuming than just giving
Yes.
free ideas. So I would say that eventually we end up with about 30 to 40% of the people who we initially asked, and this is where reviewers really got to us. They said, "Oh, come on, that's terrible, bias," and so on. And then we had to demonstrate that actually it's not. And you know, people were worried because that is certainly a bias because we don't know who we're dropping, and surely it's not
Yes.
random. But then, you know, we did what when we had an exercise with 100 people scoring, what we started doing is we started looking at what is the when 100 people score, what were the ranks, and then we started randomly choosing 5 people and look at what are the ranks of 5 people, and then 6, 7, 8, 9, 10, and increase the sample size. And we realized that once you get to 45, you get the exactly same ranks as if you get to 100, which means that, and then we realized that this is a law almost, and the saturation of ranking comes after about 45 people, which is very interesting because there's some central theorem in mathematics which says that after 45 observation or so 42 observation, I think is number, that things stabilize, and after that you can't change them easily if by adding more observations. So that's kind of like what you expect in statistical stochasticity, that after 42 observations, you will actually stabilize your results, and you won't be able to see something different if you're using well-minded people who are knowledgeable about the subject.
Sure. Thank you. Just a couple more questions. I know we're a little bit above the 5 o'clock point time. We'll take a few more questions. So, of course, you alluded to contexts, in this whole process. Can you talk a little bit more about like how it applies, to different demographics and different contexts of different countries also?
Yes,
How is that taken?
context is key. Context is key because look,
Right.
when you generalize this process, you can just talk about ideas. And you
Sure.
know, every single one of us juggles about 30, 40 ideas in the head at the same time. Some are short-term plans, some are mid-term, some are long-term plans. And
Right.
we have the three most basic criteria that we use when we follow our own ideas. One is heart, you know, attractiveness of an idea, subjectivity, because, you know, emotions. One is mind, rational, you know, feasibility. So basically, you can call it attractiveness and feasibility. And three is impact. How big impact on your life would this idea have if you start pursuing it? So those are, I think, the three most basic criteria for any idea that could lead to some activity to change the future for an individual. So now, why is the context important? Because look, there was a time in 1945 when somebody thought that it was a good idea to drop 2 atomic bombs, you know, on a country and end the war because that would kill less people than if the war continued. So that was one context. And then in other contexts, if you drop 2 atomic bombs on a country in the time of peace, you start the Third World War. So clearly, the same idea, dropping 2 atomic bombs on some country, can be obviously completely some people may think it's a good idea in one context, whereas it's a catastrophically bad idea in another context. It's probably the same for humans. So you have to understand very well the reality and what's going on and be very educated. And this is, I guess, why people who are much better educated, then they have better ideas and have better results because they prioritize better because they understand the context better, and it's better defined. But this is also why I think this misinformation is extremely dangerous for social networks, because if you make people believe in alternative realities like vaccines are dangerous and stuff like that, then they are going to be following terrible ideas, you see. So context is critical. If you understand the context well, then you can phrase and form ideas and be much better, much more assured what will happen if you follow those ideas. But if you manage to get people confused about the context and believe in disinformation, if instead of informed they become influenced, and today you cannot find information anywhere anymore, maybe on Wikipedia or encyclopedia, but all your listening is you're being influenced. There's marketing, there's influencers on social networks, the TVs are just influencing you if they're the left wing or right wing. So basically, no longer are you informed and then you create your own ideas. The ideas are you're being bombarded with someone else's ideas, and they're implanted in you. So I cannot stress enough how important it is that everyone steps away from that and learn about the context, whether it's an organization, whether it's a funder, whether it's an individual person. We need to understand the context well so that we can be informed well, and then we can make a good ideas and good decisions. Otherwise, if we don't understand and adopt to the context, we are going to be making completely bad and wrong decisions.
Sure. Thank you. So, Professor Igor, how can we measure the success or impact of, research priorities or other research that has been set using the CHNRI method? Can you talk a little bit about that?
We can't use the CHNRI method for evaluating the CHNRI method, but there have already been evaluations of the CHNRI process. So basically, we have done a number of CHNRI exercises in 2010, 2011, 2012, and so on. And then the World Health Organization has looked what happened to research funding for, say, childhood pneumonia. Did it become bigger after research priority setting exercise? Because one thing that research priority setting exercises do is they draw attention to the field. If you have some really neglected field like rare dermatological conditions, and you're a small society, or cleft lip and palate, you're a small society of people working on this, then a wonderful way of putting your finger on the map is to do CHNRI exercise, and then you publish it, and suddenly everyone's talking about, oh, look, these people got together, there is this area, and they set their research priorities. And then funders are much more willing to give if the community themselves define the research priorities. So we could demonstrate that childhood pneumonia started receiving far more, and diarrhea too, after the research priority exercises have been published by the WHO. So there was one impact. The other impact is we could look into papers that were dealing with top 10 priorities versus bottom 10 priorities on the list before and after the exercise. And whereas the bottom priorities we see the same or even less, if we see that the top 10 priorities suddenly many more people are publishing the papers over the next 10 years, then we can say, okay, see, this priority setting exercise has actually led to increased interest in the things that we defined as the priorities. And also then we can also track the funding and see, okay, more funding is going towards the things that are called priorities in these exercises. So you can actually evaluate the impact of these CHNRI exercises. And in fact, in Edinburgh, we're trying to map it all because we would like to have an impact case study. That's something we have in the UK. We need to demonstrate that our research has some impact. So this is how we will demonstrate that this method had an impact on the world.
Great. Thank you. Just the last question for today. Can you talk a little bit about the limitations, of this, CHNRI method? In your opinion, are there any challenges, limitations that people should be thinking about?
Yes. So one thing that I didn't do enough is make this a properly scientific process, turning this into a science. So now I'm thinking about rebranding CHNRI, or actually leaving CHNRI to be CHNRI for the health research, and I'm just reviewing the first 200 papers. So I'm preparing a publication on the first 200 now, and we'll learn a lot more from that. But I'm thinking of generalizing it, thinking of CHNRI just like a special case of something far more general, which is just measuring ideas, trying to develop a science of generating, assessing, and prioritizing ideas. It's a science, really, and we would like to call it ideometrics, the science of ideas. And, the science becomes a science when you can measure something. And we are here measuring ideas by using collective opinion. So we're measuring ideas, whether it's better than or worse than another one, using collective opinion. And that's why we want to call it ideometrics. So we're going to try to generalize that and then make it scientific by finding the ways to establish the sample sizes that are optimal, looking at the confidence intervals around each score, looking at agreement statistics over each question to see which questions or ideas are most controversial among the scorers, or which are least controversial, and so on. So a lot of it. And then doing some post hoc analysis, like we can use the input of various scorers to generate like three-dimensional networks of scorers and see whether there are some clusters of people who are giving the same opinion. And that's always dangerous, because we want everyone to be kind of independent, and it yes. looks like a starry skies. But if you suddenly have two big clusters, then you can try to identify what those clusters are, and then your results might be biased. So in this way, we are going to check for bias, basically, because what we have certainly found out is that people who are more program people and who are more involved in program delivery in the field, they are always far more careful about deliverability of the questions and more optimistic about answerability. And people who work in the laboratories always over-optimistic about the deliverability, but very careful about answerability, because they know. So, everyone knows better their own field, and yes. they are more optimistic about other people's area. So we need to make sure that we have a mix of everyone. Otherwise, if we just have basic scientists, they're going to be overly cautious and overly optimistic about deliverability. You have to have a very, very random mix of and diverse mix of people.
Great. Thank you so much, Professor Igor Rudan. I think a great and very, very informative presentation. We've had a lot of thank yous coming in, very informative. So we're really, really grateful for you to have taken out time to do this presentation for us. We would like to thank also all our attendees who have joined us today for the presentation. We have, I believe we have nearly reached 1,000. So thank you so much, and really, really, grateful to you, and you have a wonderful evening ahead.